Just want to say thank you very much to the chairman, Dr. Mike Block, Dr. Ole Jensen for inviting me. What an honor for me to be here. I really appreciate that. The topic I want to speak today is about immediate implant placement and immediate provisionalization. That's what topic that I'm very passionate about. We're going to show some cases. It's on literature review, a lot of literature review, but at the same time, I want to show some cases at the end. As we know, ever since the first work in immediate implants, interest had increased, to do more immediate placement. Has become the most reported surgical intervention in the anterior maxilla, according to recent systemic review. The main advantage of the immediate placement are to reduce the number of surgeries, less invasive, and also to less invasive, and also to shorter the treatment time. Give me 1 second here. Yeah, okay. The main advantages, like I said before, the immediate implant placement with an immediate provisionalization by means implants supported by a crown. Offers the patient instantaneous reestablishment and also of function and aesthetics. Immediate provisionalization enables to support the ideal soft tissue architecture from the day of surgery, while in another scenario, soft tissue, if you leave it without support, the tissue will collapse. This has a patient-centered advantages in addressing the social and aesthetic effects of having a missing tooth and aesthetic zone. But the question will be, immediate placement and immediate loading, immediate placement, immediate implant placement, immediate restoration and loading is reliable and successful as a conventional protocols. I'm going to show you, and the next slide is going to be a case that I did 13 years ago. Let's move. Okay. No, the slide here. I don't know why it doesn't show the slides there. Okay. Sorry about that. Let me see, I get familiarized with the kid. Okay. Yeah, this patient came to our office with the tooth number 10, a very loose extensive decay. As you did a succulent incision, I found that the tooth was fractured. You extracted the tooth automatically. As you press the implant more palatal and more apically. The surrounding defect, you put about some biology material or grafting material, and then you put your temporary is placed on sutures there. I like to use that because I don't want the material to go inside. And then after that, as you can see, this is a 13-year follow-up. This is what we drive for, to get something that is aesthetically pleasing to us and to the patient. And that's what we really want to achieve. Versus here, here is the same picture. As here, this is something that we see in the left slide. That's something that it shows is about position of the implant. The implant was probably, the buccal wall was too thin and produced some dehiscence, and that's not perimplantitis. That's a poor planning. And yeah. The line of my presentation, we're talking about evolution of implant placement protocols, healing of extraction sockets, timing of implant placement, prerequisites for predictable outcome, immediate provisionalization, implant transmucosal contouring. The original protocol for implant placement required a heel alveolar ridge and involved two-stage surgical procedures. The Schroeder co-workers, 1976, Brandenburg and co-workers, 1977. Immediate implants presented a more challenging option to traditional delayed implants for decades to follow. Like this, based on the principle of guide bone regeneration, Dublin co-workers 1988, co-workers 1989, were also investigated at the time and applied to peri-implant extraction defects or immediate implants in combination with open flap procedures. Lazara, 1989, Becker, 1990, Lan and co-workers, 1994. Early in the studies had shown that implant placed into fresh suction sockets could successfully achieve osseointegration. Barsali and co-workers, 1988, Barsali and co-workers, 1991, Paolo Antonio and co-workers, 2001, but the higher implant failure were also reported by Schwartz, Chesu in 1997, and Mayfield, 1999. But in late 1990, new studies emerged to demonstrate that not only immediate implant placement was possible, but also immediate loading of the implants with World 1998. However, the initial clinical results with immediate implants or immediate loading were not always satisfactory, particularly in regard to study outcomes. Chen and co-workers, 2004. The introduction of the implants with moderate rough surfaces provide a better understanding of the bone implant interface and healing processes, as well as occlusion and proper prosthetic design. Along with improvements of implant design, immediately placed and loaded implants slowly gain acceptance among scientific community and among clinicians. This is Avila and co-workers, 2007. Following the accumulation and extensive body evidence, both immediate implant placement and immediate loading have become accepted clinical procedures within the indicated conditions. Busser, 2017, Galucci, 2018, Kant, 2018, Seises, 2021, Su, in 2021. And we can see here, this is a very good article that I took from the Journal of Periodontology, 2005. It's a dimensional ridge alteration followed with 2 extractions. This is an article written by Dr. Professor Lindet and Araujo. Give me a second, one back here. The first, as you can see here, the dimension, the slice that we have is 2 days, 4, is 1 day, 2, 4, and 8. And the 2 weeks, we can see, we can see on the top, the suction socket is filled with clot in the apical portion and lateral portion. And we can see that a lot of provisional matrix on the top of the crest. But the 2 weeks, we can see the provisional matrix is on the top and we filled with human bone. And we can see that the apical, the coronal portion, the buccal and lingual is still the same high. Versus at 4 weeks, we can start seeing some alterations of this provisional matrix, and also we can see that it's filled with bone marrow. The crystal, at the top of the crystal is completely sealed. We see the lamellar bone, also the wooden bone, form that completely that crest of bone. At 8 weeks, we see that you compare that between the 4 and the 8 weeks, you can see the buccal wall, but the coronal portion is a little bit, as you see the arrow, is 2 millimeters lower than the counterpart, the lingual. And the 8 weeks, you see that the crest is completely healed, but the recession is already even more, but it's filled the socket of bone marrow. Now, this is another article I took for the ridge alterations following implant placement. This is a fresh extraction socket. It's also an experimental study in dogs by Linda and also Professor Araujo. Journal of Clinical Periodontology, 2005. Sorry about that. Okay. As you can see here in the slides, you can see the 3 cuts that we have. We can see that if we look at it, the moment you put the tooth on the extraction site, and the structure on the slide number 1, we see that it has been demonstrated that osseointegration and implants placed in fresh extraction sockets was predictable outcome. That was Chen and co-workers, 2004. And took place irrespective of the gap between the implant surface and the bony socket walls. The study proceeded to investigate a psychological process of socket healing combined with immediate implant placement. Initially, proponents of immediate implants as a novel therapeutic concept argue that it may counter out at post-extraction buccal bone resorption, benefiting from the supporting role of the two and hence provided better study results. Lazara, 1989, Dennison and co-workers, 1993. However, subsequent studies yield contradictory results, namely that resorption changes after two extraction occurred independently of the timing or implant placement and immediate implant failed to prevent them. That's Botticelli and co-workers, 2004, Araujo and co-workers, 2005, Chen and co-workers, 2007, and Araujo co-workers, 2006. Now you can see we have the first slide is a baseline. We have the second is 4 weeks, and the third one is 12 weeks. As you can see, the buccal wall, the thin buccal wall, starts to be very, very thin. The buccal wall starts to be very thin, and they say that there's very intrinsic present in the anterior maxilla, and especially around a more prone to resorption. Araujo co-workers, 2005, hypothesized that the coronal part of the buccal bone plate was often made only of buccal bone, which the part is part of the periodontum. When you take the tooth extracted, basically you take that bundle of bone, it disappears. And then what happens is the bone is useless. They say it's Ferris and co-workers, 2010. And additional damaged facial bone with fenestrations and any kind of dehiscence in the bony walls will make the bone weaker and more prone to resorption. Khan and co-workers, 2007. While signs presenting thick buccal bone, exhibit less dimensional changes of the alveolar ridge after tooth extraction. Chapulis and co-workers, 2013. Chapulis co-worker, 2015. Other risk factors include a thin periodontal phenotype. Evans and Chen, 2008, Bordaro and co-workers, 2009, and an Iverton facial malposition of the implant within the socket of placement, Chen and co-workers, Evans and Chen, 2008. These findings led researchers to combine immediate implant with alveolar ridge preservation procedures. They involve grafting the peri-implant socket defect with bone substitutes to limit extraction remodeling and to achieve a better long-term functional and aesthetic outcomes of implant restorations. Chen and co-workers, 2004. The current evidence seems that to indicate a trend towards better outcomes when implants are placed immediately in a flapless approach, combined with socket grafting plus connective tissue grafting in patients with a very thin soft tissue phenotype. Sinsis and co-workers, 2020. Sinsis and co-workers, 2021. Now we're talking about timing implant placement. We talk about it's type 1, type 2, type 3, type 4. Type 1 is in immediate placement the same day. Type 2 is early placement with soft tissue healing, 4 to 8 weeks. Type 3, early placement with partial bone healing, 12 to 6 weeks. Type 4, late placement, 6 months. The type 1 is immediate loading. That's what we all want to achieve, is to distract it, preserving the buccal wall. You don't want to do the extraction automatically. You want to place the implant more apical coronally position. That's one of the advantages. The advantages we're going to give the patient that tooth, the implant with the restoration the same day, shorter amount of surgeries, and also it's less invasive. And at the same time, it's going to shorten the treatment for the patient. One of the disadvantages of that is that you cannot close the tissue. You place the implant, basically, you're not going to be able to do a primary closure. A second disadvantage of that is you can place the implant, if you do using some type of guide, you put it in more prosthetic position. The type 2 and the type 3, the disadvantages on is the type 2, the pathology, you can see the pathology is completely restored. You see it's a 2 to 3 wall defect. You have more keratinized tissue. The advantages of this case, if you decided to place an implant, you may place it in the wrong position. or you don't get the stability you're looking for. And type 3 implant are the same way. You see the ridge is completely closed, but you notice a very resorption of the buccal and also a cortical resorption. And what it means is you have to delay the implant placement, or you have to do some type of GVR to be able to reestablish the position, ideal position for your implant. The type 4, as a late placement, 6 months, as you can see, the ridge is completely formed. The tissue is already closed, but this here, we can't do the implant. We need to wait. This is a longer, the disadvantage of this procedure is a longer time to do the surgery, the prosthetic, the implant placement and the prosthetic is a longer treatment time. Now, the implant placement and the implant protocols, that's something that there are two separate things, but we need to really present it in the case with the definition of what is immediate loading. Dental implants are connected to the prosthesis with 1 week after implant placement. That's type A. Early loading, dental implants are connected to the prosthesis between 1 week and 2 months after implant placement. That's type B. Type C, or conventional loading, dental implants allow a healing period of more than 2 months after the implant placement with no connection to the prosthesis. Now, this is also, I took it from the Stroman at the article. I took it thanks to Dr. Gianmangalucci. The implant placement, loading protocols in partial edentulous, patient as systemic review. Thanks to Dr. Galucci and Dr. Daniel Busser and Stephen Chen. As we can see, we have an implant placement protocol. We have immediate placement, type 1. As we'll see, the early placement, type 2, 3, and late placement. But looking into the loading protocol, we say the tie-up, immediate restoration loading, and immediate placement, that is clinical documented. And early loading, immediate placement with early loading is also clinical documented. But if we do a delay, a conventional loading in type C, now this is scientifically and clinically validated. The early placement type 2 or 3 and immediate loading and also the early loading is clinical insufficient documented. As we see, and also in the late placement, type 4, we can see is clinical documented. What are the prerequisites for predictable outcome? As you can see, this is the tree that we have. This is also, I took it from the international team on implantology. Guys, thank you to Dr. Germán Galucci and also to Galucci and Chen and also Dr. Busser. As we can see, the first line is the tooth extracted. And then the second line, we talk about the second line here. Yeah. Now, in your mind, you think about how you want to. An implant shoulder. An implant shoulder. We have the intraoperative assessment. You want to evaluate to see if you have one, how many, it's how many the suckle is prepared to do it. You want to use a probe, you want to check it. La primera stability, you want to be sure that, and we even. La primera stability, to be sure that the bone is ready to place the implant, the sucker wall is intact, and preventive stability is achievable. Also, to be sure that ideal implant position is possible. Placement protocols, as my focus, my presentation is type 1, immediate loading. We need to check when we do the loading protocol, we need to concern about insertion torque. It needs to be around 35 Newton centimeter. Or still, ISO, it has to be around 70. And don't direct primary contacts in no parafunction. If in any of this case you can't do that, and you look at your CT scan and you think you cannot do you cannot do the implant placement the same day, then what you do is you check it out to see if it's pathology. Sometimes the buccal wall is too thin. Then what you do, you just graft it, come back later on and place the implant. You can do it in 12 weeks. You can do it in 8 or 12 weeks to place the implant for the lower, and you can do 4 months for the anterior tooth, superior tooth. Immediate provisionalization and implant transmucosal contouring. This is very important here to see the transmucosal. The vertical and the horizontal is very important to know to establish what type of phenotype we have in our procedure. You want to be sure if you want to place your temporary, if you say you do a temporary with the compass design, you want to have recession and you're going to have dehiscence of the tissue. The palatal seal is formed for, the implant seal is formed for junction epithelial and connective tissue. So doctors say that the concave concept, that's the way to do it, to preserve the tissue and also to maintain healthy periodontium. In the subcrestal platform switching, we can see that the bond is preserved in the concavity of the preparation and the temporary. Here for temporalization of this particular area too, we use a stainless steel metal. You can use a prefabricated stock abutment. You can use a plastic abutment. Basically, you measure, you put some Teflon, or you do the like pattern, composite, whatever you want to use it, just to cover it. If you want to use the polycarbonate shell, you want to use a hole to reline it, and you want to basically create the concavity of that temporary without putting polishing, without varnish. It's very important that when you do that, the surface is completely polished. And then in this case, we have a planning. We have a patient with a tooth number 8, sternal resorption, fracture. You do your planning and your software. You can use any software you want, 3D diagnosis, Blue Eye, anything like that. You do your planning, and you know where you want to follow the triangular envelope, like a skull gas. Say he created the triangular shape to place it through the vertex. You use a tooth supported guide. You want to remove the tooth automatically as possible. And then when you put the surgical guide, you want to do basically in the right position, prosthetically driven. You want to fill the socket, again, like we told you before, with the bone graft around it. You put your temporary, you trim it, you polish it, and then you screw retain. This is the temporary. This is what you're looking for. This is what you want to achieve. Follow the temporary for 4 to 5 months. You just basically, you work with the temporary until you get the shape of the tissue contour, until you are happy with the results, and then basically you proceed from there to the final restoration. Here, this particular case, we have a patient coming with a broken tooth, 22. The tooth is extracted automatically. Before I do that, I plan the surgery. I say, okay, well, I'm going to do this. I'm going to take my CT scan. I'm going to do my intraoral scanner. I'm going to dicon. I'm going to a surgical guide. I'm going to do the extraction flapless. I'm going to take the tooth out. I'm going to place the implant. I'm going to put grafting material and that 360 degrees of the defect that you have around the implant. And then you use, in that case, I use a Ditron implant. You use LPRF. It's very hydrophilic. You can see the surface completely away with the poor plasma. You place the implant. I use one of the stock abutments for them, and I use Teflon tape to cover it. I can be able to have copy of the temporary. Those patients who walk the same day at your office. You have all the tools to be able to do that. You take an impression pre-matrix, like an Aginet, and you have the copy of the tooth. This is how I did it. And then when I put the stainless steel abutment with the Teflon tape, I reline the temporary, make it aside, reline it, and cement it. The other case here is a patient with the bicuspid number 5, come to for extraction of the tooth fracture. You do the planning, you do the software, you want to do it, intraoral scanner, you put your temporary 5 months, you play with the temporary, start looking for the tissue you're looking for. As you can see the soft tissue contour around the implant. You take the temporary out, you want to duplicate that tissue that you created, and you took time to create it. You want to copy that with a PBS impression. I use Duralite pattern. I put it all around the open tray. I put it in the open tray, I put it in the patient, take an X-ray to be sure it's sitting correctly, and do analogous technique to use PBS to take an impression. You can use also body scan if you want, but the only thing with the body scan is how are you going to copy the tissue contour or the gingival contour or the gingival profile, because you don't have reference of that. You can, but it's not the same. You're going to have to anesthetize the patient, because when they come back, the technician, you're going to let the technician to do that for you. You're going to have to anesthetize the patient to deliver the crown. This way you don't. You take the temporary out, screw retain, and put your crown back in, and screw retain. Here is another technique. I'm working on it. It's a tooth come out with a broken tooth, a molar, number 3. I plan it. I'm going to take the tooth out. I'm going to do lift the sinus, lift the sinus, LMSF, localized management of the sinus floor, and I'm going to place the implant. Then you take the tooth out robotically. You section the tooth. Never take a tooth in one piece. You section the tooth. Use your tooth supported guide. You place the implant into the sectum, and then you're going to place. Your planning is going to be 1 millimeter shorter than the sinus floor. And then basically you're going to use an automatic magnet. You can use ham osteotomes. Lift it very, very slightly, and then you put your implant. You can see 3 millimeters, less than 3 millimeters I have in that specific area. I lift it and I put I think that's 11.5 by I think so 4.2, 4.3. I'm very happy for the healing abutments that we have. But now, thank you to the new system I saw outside, the nanotemp. That is something that is going to save our lives in short time, because when you do procedures like that, you put the temporary, then it forms the emergence profile, and at the same time, you can take an impression. There's only one time. That's what we're treating for, to one time abutment, to leave it there without distort. You scan it, send it to the lab, you check the number with the anatom, what you use for, and immediately you want to say, okay, now let's go deliver the crown. That's something that I found that I really like about that, and I can't wait to have it in my hands. Here is another way I do it. I do a customized healing abutments. I take a CT scan, intraoral scanner. I plan my surgery. I'm going to do the surgery in that case with flapless procedure, soft tissue punch. Be careful when you do the soft tissue punch, keeping the keratinized tissue around it. The healing abutments are fabricated. You do the implants, you put your healing abutments customized. The disadvantage of that one is it has to be very perfect according to the surgery, according to the planning with the 3D diagnosis or with the software that you use, because it has to completely fit in your implant. The other way to do it is you section the tooth, and then you put your implant, and then you're going to create with composite, fluid composite around the healing abutment, you create the emergence profile or tissue contour. That's something that I like it. But now again, we use the nanotemp. That's something that's going to make our life very easy, because now we can just leave it there and never come out after the day of delivery of the crown. That's something that we're driven today to do one-time abutment. Here, as you can see, we have several cases I'm using the implant, UTL. I really feel as comfortable with the implant. I like it. I was before another implant system. I'm very comfortable. I'm using a lot for that technique. As you can see, a tooth here was extracted. A tooth was extracted Here, a tooth was extracted. This is an implant, a Zimmer. It broke off. Coming to me and I say, okay, what we're gonna do? I took that out the same day, and because of the taper of the walls of the implant, I was able to place the implant right away. In several cases like that, as you can see, a lot of the localized management of the sinus floor, I have over a lot of cases that I have done, and it was wonderful. You can see also here in the bottom, you can see here in the bottom, you have a tooth molar, basically to be extracted. You section it, and you put the implant in the dissected area using a nice clean environment on it. I just want to say thank you very much. I'm really sorry for the confusion here with my slides. My computer never really moved. I just depends for using 3 tools here to be able to get it, but unfortunately, took a little bit long time. Anybody have any question? This topic is really, really important about anterior tooth implant placement. When they gave me the topic, I said to myself, oh my God, how we're going to talk about that? But I did references to be able to sustain what I say.
Thank you very much.
Thank you very much, man.